Great. I think we should get started. Good morning, good afternoon, and good evening, everyone. My name is Laura Giron, and I'm a member of the ExpandNet Secretariat. On behalf of all of my colleagues, I'm pleased to welcome you to this meeting of the Health Technical Working Group of the Community of Practice on Scaling Up Development Outcomes. The Community of Practice is led by Larry Cooley of Management Systems International and Johannes Lin of the Brookings Institution. And ExpandNet, which I will introduce in a moment, chairs this Health Technical Working Group. Hopefully you had a chance to participate in some of last week's proceedings, during which a range of experts provided cross-sectoral insights on how we can scale up in the face of both the usual and the inevitable new obstacles. This is the fourth event of the Development COP's fifth annual workshop, and our technical working group is one of 9 in the Development COP. While in years past, the annual meetings took place in person in Washington with a smaller group of people, the silver lining of this year's format is our ability to involve many more people from around the world, and we're delighted to see that many of you are with us for the first time today. For those who are not already members of the umbrella Community of Practice, we extend a warm welcome to you and your colleagues to join. The Community of Practice is a voluntary and free resource open to all that is dedicated to advancing the practice of scale-up by learning across sectors, geographies, and perspectives. In addition to organizing the annual workshop, the COP circulates quarterly newsletters, and the working groups explore scaling up through the lens of the various sectors and thematic issues in the context of quarterly virtual meetings. Each working group will have its own webpage on the new Community of Practice website that's being launched on October 30th, and I'll provide the address at the end, and we'll email it to you as well. Recordings of this year's plenary and technical working group sessions, including this one, will be made available on the website, and please note we are recording today. So, as I mentioned, I'm a member of the ExpandNet Secretariat, and for those who do not know us, we're an informal network of global health and development professionals who seek to advance both the science and practice of scale-up. ExpandNet's history of working on scale-up goes back to the mid-90s, and our connection to Larry Cooley and MSI's scale-up work goes back to the mid-2000s, when the topic of scale-up was not nearly as widely addressed and discussed as it is today. Since the founding of ExpandNet in 2003, one of the public goods we've been providing is to curate a rapidly growing bibliography of scale-up resources and publications. We've always felt it's important to bring scale-up learning from different health fields together with other sectors, which is one reason we're so pleased to serve as chairs of this working group. Our bibliography is freely available on our website, together with our scaling up guidance tools that we jointly developed with the World Health Organization. Please let us know if you have any recommendations for additions. Given ExpandNet's core mission to advance scale-up in public health and development, we want to help ensure that prior experience informs how we all work on scale-up today. We want to benefit from rich learnings from a range of relevant disciplines and literatures, including implementation science, the diffusion of innovation, research utilization, policy and practice, and of course, insights from the political, policy, management, and social sciences, as these are all useful in shaping our scale-up plans, strategies, and processes. We know that there are a growing number of theories, frameworks, and tools to support scale-up, and we see intersectoral dialogue based on practical experience as immensely productive and valuable. Can you advance to the agenda slide for me, Janet, please? I wanted to share a bit of background on this Health Technical Working Group, and then I'll talk about today's agenda, which, as you can see, is focused on both hearing from key scale-up thinkers, as well as charting the Health Technical Working Group's future activities, a task for which we're seeking your guidance today. So first, a bit of background. For the last 7 years, please go back one actually, Janet. One more, back one more. Thank you. So for the last 7 years, ExpandNet has worked with the USAID-funded global flagship family planning project called Evidence to Action to convene an allied community of practice focused on systematic approaches to scaling up best practices in family planning and reproductive health. I'll refer to that as FPRH. Pathfinder International's Evidence to Action project and ExpandNet worked jointly with the Development COP over the last 4 years to have the FPRH Scale-Up community serve as the Health Technical Working Group. However, starting this month, the leadership of the FPRH community is transitioning to our longtime Scale-Up and Research Utilization colleagues at FHI 360. And they'll be working on that in the context of their USAID cooperative agreement called Research for Scalable Solutions. In partnership with this development COP and the leaders of this development COP and FHI 360, we agreed ExpandNet would work to diversify and expand the membership of this Health Technical Working Group to incorporate many more global health technical domains beyond family planning and reproductive health. We're excited about this opportunity, and we're hoping you'll continue engaging with us in this health working group as we interact with scaling up professionals across a wide range of public health technical areas. For example, HIV, tuberculosis, malaria, and other infectious diseases, chronic diseases, maternal and child health, water, sanitation, and many more. I want to give a quick shout out to the chairs of the Nutrition Technical Working Group who are hopefully with us today. And we want you all to know that there's no limit to the number of working groups you can join, only limits on your time. So given our desire to expand to a wide range of health topics, today's session will include a discussion where we would like your input for how to bring into the COP more colleagues working on diverse health topics, as well as to learn what scale-up topics you'd like to see the Health Working Group focus on in future sessions. Janet, can you move 2 slides to the agenda for me? So this invitation to participate is open to all health professionals seeking to contribute to and gain from scale-up learning. We are planning to add all of the registrants of this meeting to the distribution list unless you tell me otherwise. Please know that this will be a low intensity commitment with hopefully a high potential benefit for your scale-up work. We'll be organizing approximately quarterly virtual meetings where you can share and hear from others who are working on the front lines of scaling up in countries and at the global level. So onto today's agenda, you will have the chance to hear from 2 senior colleagues whose work has been highly focused on scale up for the last several years. Both are medical doctors with advanced public health training, working in different ways to build the field of scale up. I'll introduce them in a moment, but I also want to recognize my colleagues from the ExpandNet Secretariat, Ruth Simmons, Peter Fyans, and Rebecca Lundgren, all of whom are with us today and who you will meet in the small group work. So as we hear the remarks from our 2 invited speakers, I hope you'll all pose questions or comments to them in the chat box, and we will try to address as many of these as we can in discussion and to the extent possible afterwards. So our first speaker today is Dr. Steve Hodgins, who's Associate Professor of Global Health at the School of Public Health, University of Alberta, and is also the editor-in-chief of the high-impact journal Global Health Science and Practice. Throughout his more than 30-year career, Dr. Hodgins has been preoccupied by the question of how to achieve sustained improvements in health status at scale. Before moving to the University of Alberta, he was based in Washington for 8 years, first as technical director on USAID's Maternal and Child Health Integrated Program, or MCHIP, and then as senior technical advisor on the Saving Newborn Lives project. The focus of his work has been maternal, newborn, and child health, particularly in South Asia and Sub-Saharan Africa. He's especially interested in on-the-ground challenges of effective implementation and scale-up, as well as the role of adaptive management. Thank you for being with us, Steve. You have the floor.
I'll just get my screen up here. Okay, thanks a lot for that introduction, Laura. So today I'm going to be offering some broader framing perspectives, a 30,000 foot or a 10,000 meter view, if you like. After that, my colleague Jim will be getting into more of the kind of close to the ground nitty gritty. Much of what I'm going to be saying will be familiar to most of us, but I think in the context of today's meeting, I think it's still good to remind ourselves of this bigger picture. So over the next 10 or 15 minutes, I'm going to be making 4 related points, looking at, let's see here now, trying to get my screen here to move forward. Okay, so I'm going to be looking at blinkers, the middle piece, the package and delivery vehicle, and the way forward. So for most of us, our work is confined to particular technical areas and often to a limited set of interventions or approaches. Part of the reason for this is the heritage that we draw on for our program work. And this has included the Disease Control Priorities initiative pioneered by the World Bank and then taken up by other major players such as USAID and the Gates Foundation. It draws on selective community-based primary health care and the kind of the thinking and the philosophy behind that, and the Millennium Development Goals. And this stance has entailed a focus on a limited set of presumably evidence-based interventions or approaches that are understood to be effective in addressing specific high-priority issues of health and well-being. This has been valuable. It's been powerful. Undoubtedly, it's made an important contribution to at-scale population-wide impacts. So I'm certainly not arguing that we throw out such an orientation. There is, however, a cost to a narrow focus that's only concerned with the specific interventions we're working on. One potential cost is that in our effort to pilot or introduce a new intervention, we may produce unintended negative consequences in other parts of the system that we fail to notice. Some 15 years back, I was working in Nepal on a pilot of an approach to extend case management of possible newborn sepsis to community level. The model that we were promoting entailed having community health volunteers do home visits, during which they were able to identify cases of possible sepsis, and they in turn were to help arrange to bring the local paid village health worker to the home to administer injectable antibiotics. Now, early in the development phase for this initiative, we were visiting the field with a senior Ministry of Health official. And as we were discussing the proposed work, he pointed out that these village health workers were the backbone of outreach immunization services. Wasn't it possible that adding home visits to provide treatment of possible newborn sepsis could take time away from their vaccination duties and undermine immunization coverage? We agreed, and at his suggestion, we added local immunization coverage rates to our monitoring indicators for the pilot. Even without specific unintended consequences in other program areas, any new program initiative has opportunity costs. In addition to financial costs, every program initiative commands the attention of the system, drawing attention away from other areas that could otherwise be getting attention. This could be understood as an hydraulic effect, or sucking oxygen out of the room. For about 10 years, a big part of my work, and the work of many others engaged in newborn health, was piloting, promoting, and scaling up postnatal home visitation programs. Early piloting and robust community-level cluster randomized trials had shown this to be efficacious in driving down newborn mortality rates. Over the period from roughly 2005 to 2015, this was the single intervention strategy or approach that received the most attention in global newborn health. But as evidence accumulated over that decade from more and more countries where there had been wide scale up, what we found was that as this strategy was scaled up, in most cases, it proved not to be feasible to ensure high fidelity under institutionalized at-scale conditions. The problem here is not just that it didn't really work. It was that this effort sucked the oxygen out of the room. It monopolized resources and attention that could have been directed to areas where it could have done more good. The middle piece. For a variety of reasons, for those of us working with donor-funded technical assistance programs, we tend to be incentivized to focus on the intervention or the innovation. Part of this, I believe, is an idolatry or a fetishism of innovation and related preoccupations about what's likely to appeal to funders. Associated with this intervention or innovation focus, we're also incentivized to give more attention to issues related to piloting, advocating for adoption, and supporting the inception process. And we tend to use the word implementation for these inputs required to start something up. We tend to give less attention to issues of ongoing effective delivery, program performance, and institutionalization. So another use of the word implementation can be all that it takes to continue to effectively deliver some service at scale. So the middle piece that I'm talking about includes what happens after proof of concept piloting and policy adoption. It includes proof of scale piloting and ongoing iterative adaptation as new interventions and programs are progressively mainstreamed. And it includes continued vigilance, ensuring robust delivery and sound program performance, measured particularly in effective population coverage. So that is the proportion of those needing an intervention that actually get it, delivered in such a way that it can be expected to produce its intended benefit. So again, I'm reminded of things I learned from colleagues in Nepal. JSI had a long and distinguished presence in Nepal, working in child health and other areas. I learned a lot from colleagues who preceded me there, both Nepali and expat, who exemplified an approach that certainly included innovation and pilot testing, but it also focused on this critical middle piece, including proof of scale piloting and continued vigilance and attention to performance of programs operating at scale. This was evident, for example, in work done beginning in the early 1990s by JSI with key partners at the Ministry of Health and in the Nepal Pediatric Society on community case management of acute respiratory infection and diarrhea in young children. And this ended up serving as a model for ICCM work done in many other countries since then. The package and the delivery vehicle. As I mentioned at the beginning, our work builds on a heritage in global health that is focused on introducing and delivering at high population coverage a limited set of efficacious interventions targeting specific priority health issues. So this has meant focusing on content, interventions, or packages of interventions. To a limited degree, we have paid attention to specific systems issues that are clearly relevant for delivery of these interventions, notably commodity logistics, if our intervention entails use of a commodity, tracking indicators and M&E, health worker training and supervision. But we've tended to pay disproportionate attention to the package or the content and insufficient attention to the delivery vehicle, which also, as it happens, is generally responsible for delivering lots of content beyond the specific packages that we're focusing on. So as we noted, for example, in the case of village health workers distracted from their vaccinator role. So my call is for due attention to the delivery vehicle. And I'll briefly return to this under my final point, which is the way forward. Now, just back up here for a second here. So as I've noted, in many ways, we've been well served by a way of working that's well reflected in the MDGs, under which we focused our effort on identifying, introducing, and delivering at scale efficacious interventions, which in turn have resulted in impact at scale. But we're now 5 years into the post-MDG era, and we face new challenges in maintaining momentum. Health issues are now less visible under the broader SDG framework. We now have prominent leaders in global health promoting a vision of universal health coverage, in which delivery of specific efficacious interventions at high population coverage doesn't necessarily feature. Instead, the focus tends to be on financial risk pooling and expanding the package of covered services. But we have allies and potential allies in our work. Some of our old partners from the World Bank, Johns Hopkins, IHME, and others, have stepped in to make a persuasive case that attaining and maintaining high population coverage of key interventions targeting the highest disease burden conditions needs to be understood as integral to universal health coverage. And here's an important paper that they've contributed making that case. There are others who may not be talking about interventions or scale up per se, but are nevertheless very much focused on the actual content of our programs and services and the extent to which it's reaching those who need it. And here I'm thinking of those working on quality of care, performance improvement, and adaptive management, and those engaged in health systems work who at the same time are very preoccupied with what's actually being delivered by those health systems. I think that one of the most important things we need to be doing going forward is to be building alliances with those with similar preoccupations. We do that in part through communities of practice like this one, and I strongly endorse our strategizing together on how best to bring others in and broaden our base. But we can also reach out and join together with other networks and coalitions that are similarly concerned about ensuring effective delivery of content, interventions, and services that improve important outcomes. So we come together for a couple of reasons. First, we learn from each other. And wearing my editor hat, I would argue that robust self-critical documentation and dissemination of program experiences as we seek to contribute to effective programs delivered at scale is a critical function. And secondly, and this is my final point, I think we come together because together we have a stronger voice and more influence. And in that way, our work can produce greater benefit. Thank you.
Thank you very much, Steve, for those remarks. We greatly appreciate you sharing these insights that you've drawn from your collaborations in Nepal and elsewhere, and from your vantage point at the Pan Health Journal Global Health Science and Practice. You've given us a lot of important food for thought about staying vigilant to our unintended impacts on the systems we're trying to strengthen. And I especially appreciate the delivery vehicle analogy. Also, thanks for the important call encouraging us to continue building the field of scale up collaboratively as well as in our own sectors. And because after all, our goal is to advance global health, so collectively. Our next speaker, Dr. Jim Ricca, is the Director of Adaptive Management, Monitoring, Evaluation, and Learning for the Johns Hopkins affiliated NGO JPIGO. Jim is currently working with the USAID-funded Momentum Country and Global Leadership Program, which focuses on maternal, newborn, and child health programming in 18 countries across Africa, Asia, and Latin America. Jim is a family doctor and public health specialist who brings extensive scale-up and knowledge management experience to his role on Momentum. Jim's worked on projects in over 40 countries and has lived in Honduras and Mozambique. And he'll be addressing key scale-up related learnings from his collaborations during the USAID-funded 5-year Maternal and Child Survival Program, or MCSP, which ended late last year. I want to, before I give the floor to Jim, send a reminder to everybody to please use the chat box to pose any questions to our two speakers. And then they will jointly address them after Jim's remarks. Okay, over to you, Jim. Thanks.
Thanks, Laura. Thanks very much for the opportunity to speak. I just want to share my screen. It'll just take me a second here.
And if
Hopefully,
you want to share your video, Jim, either way, up to you.
I hope that I am sharing. Am I? Okay, I'll assume that I am.
I don't see your video, so I only see the screen.
Oh, my video as well?
There you
Okay.
are.
Yeah, am I there? Okay. And I hope I am sharing my screen as well.
Yes, we see your screen.
Okay, great. Well, thanks. Yeah, so I just want to thank you, Laura and Ruth, for the opportunity to discuss a few examples from country level scale up of RMNCH interventions that we did under the Maternal and Child Survival Program. And as you'll see, some of these cases were more successful, some less. Laura, along with Ruth, Steve Hodgins, Larry Cooley, and others helped us to really not just support these interventions, but also learn from the experience. And I'd like to draw out some lessons that we learned. We called these advanced scale up because all of them built on years of previous experience in the country with the supported intervention. But the intervention also in all cases had not achieved widespread coverage. So I just want to be clear, these are all cases in which our goal is sustainable impact at scale, at a national level scale. And I also want to start by saying that this work and other work in supporting scale up happens against a global health backdrop that, as Steve said, is not always conducive to successful scale up. And I just want to point out a few things, some of which Steve already has pointed out as well. So first, donors often value innovation, like Steve has said, and so that directly means that they're more likely to fund innovation over scaling up proven interventions. And secondly, the kind of sucking the air out of the room piece as well. That happens, longitudinally in some ways. One intervention that is an innovation at one point in one funding cycle is no longer a innovation at the next funding cycle. And so the new innovation, the new shiny thing kind of sometimes gets funded in the next cycle, meaning that there's not as much attention or funding for the previous thing, just at that stage of vulnerability when it's in need of extra attention to really be able to successfully scale. If we also look at ourselves, I mean, assuming that some of us are also from implementing partners and technical agencies, like I am, we want to be able to take credit a lot of times in terms of our incentive structure, to be able to say that something worked. And it's easier to demonstrate that in a small controlled environment than it is in kind of a large, messy environment where attribution is a lot harder to be able to draw a line to. And then journals and academics often want to look at issues in a controlled circumstances. The highest impact journals, where academics get the most credit for publishing, have a measuring stick of evidence that favors what I call, or not just I call, a lot of people call internal validity. And they favor that over real world external validity. Does it really actually work in the real world, and can it be generalized? And the randomized control trial was held out as the highest expression of this kind of scientific rigor. And I'd say that even with its drawbacks, of course, the RCT is in fact the gold standard for small controlled studies at the proof of concept stage. But as we go to scale, RCTs are not practical. And even more importantly, because of the nature of an RCT and having to control multiple variables that cannot and actually should not be controlled in real implementation settings, they're actually not really appropriate at all in scale. And so the data that we actually are getting at scale is spotty a lot of times. And as well, so we can sometimes get away with declaring victory even where there hasn't been a victory, because there's not data to show that we haven't in fact been as successful as we might have hoped. And a consequence of this is that there are many times empty scale up. That's a term that Steve has used before. That is incompletely scaled interventions that actually are achieving little or no impact. So I just want to kind of show you this graph. It's kind of an idealized graph, but based on real world data of how long it takes to go to scale. And there, as you can see, very large variation. And I'd like just to point out a few things, maybe that aren't on this slide per se, but kind of some evidence that's out there. According to a widely cited study on knowledge translation from the United States, to go from a good idea to impact at scale takes an average of 17 years. So that's even in a high income country. And that's just for the small minority of interventions that actually do go to scale. So if we translate that to concrete terms, if we're going to even do this well in an even more challenging setting in an LMIC, then it implies that we need to go through 3 or 4 typical 5-year project cycles. And if we conceive of the scale process of kind of having a phase of innovation and piloting onto expansion and full scale, so these kind of 3 phases, that means at least 1 project cycle per phase. And I know that's overly simplistic, but I think it's kind of a good starting point for thinking about how long this all takes and what the pace is likely to be. So this is just a very simplified theory of change that we used to kind of look at how we were trying to support scale up at a national level for the cases that we're about to look at under the Maternal and Child Survival Program. So we just started out over here, first of all, on the left side of the slide, with looking at what the inputs were, or kind of where we thought the starting point would be in a number of the cases. There ought to be enough evidence about the intervention, including in real world and contextual trials, to know that it's actually effective at small scale. There should be supportive policies already in place. And I know sometimes we're working in places where that's not the case, but we figured a minimally supportive policy. And there should be some financial backing for, at least being able to start out the process or to move on to being able to do the process as envisioned. So then switching over to the more downstream, we can say the goal of the scaling process was to get this high impact intervention, practice, or behavior to significantly improve and contribute to national goals by achieving widespread and sustained impact. And then to do that, we figured that there should be what ExpandNet calls both horizontal and vertical scale up. That is, horizontal, there should be widespread service delivery, and also vertical, that it should be actually incorporated or institutionalized in various health systems. And we took this little piece out of the Consolidated Framework for Implementation Research, kind of mashed together with some bits from ExpandNet to kind of say what it was that we figured was happening, the engine, so to speak, to drive this process, and to be able to kind of describe what was happening. There are leaders and managers, or what would be the resource team in ExpandNet that are actually kind of trying to push forward the process. And at the bottom, there are providers and clients. They need to be able to go through an adaptive management cycle in which they're engaging others, planning, implementing, reflecting on what's happening, and continuing to mobilize resources. So we kind of tried to take each of those pieces and support those, and not necessarily supporting all of them. We didn't necessarily, even though we might have wanted to, have the mandate to support all of them, but also additionally, there were some pieces that maybe were already in place. So I don't have time to get into almost any detail at all about the 5 cases that we looked at the most carefully, but I just wanted to give at least a little bit of a sense about what they were and kind of where they got to, where they started and where they got to. So if we're going to look at the horizontal scale up piece or improvements in service coverage or utilization, then these are the 5 focus cases that we studied and supported the most intensively under MCSP. This includes postpartum family planning and Helping Babies Breathe, which is a facility-based intervention for improving neonatal resuscitation in Rwanda. chlorhexidine in Nigeria for prevention of of neonatal sepsis. Integrated community case management in the DRC. Misoprostol at the community level for prevention of postpartum hemorrhage for women delivering at home in Mozambique. There's further reading on the last slide that I have, so those who are interested to get more detail, there are some self-published and some published in the peer-reviewed literature studies on these particular things. As you can see, there's a broad range of where things started, but also how much additional coverage they were able to attain. And this is service utilization, not just availability of the intervention. And this data, again, for those more interested in this, was not easy to come by, but you can read about how we tried to estimate this. So I just want to kind of spend some time thinking about some of the lessons that we learned from supporting these various interventions, and some of this idea of the middle space between innovation piloting on the one side and routine practice at scale on the other side. So at scale, there's a need for integration in all the country's systems, including service delivery, the service delivery model. And the question is how to turn this corner and the pace at which to do so to get to that routine implementation at scale. And I'd say that the lesson is that we need to be system aware and not necessarily project-based, but not to rush too quickly and to assume there can be full integration too soon, because these things are not yet routine. And so the intervention, even in that middle space, requires additional attention for an extended period of time. So in terms of planning, plans can't just be project plans, but they also can't just be incorporated into Ministry of Health 5-year strategic plans, or they'll get lost in the weeds, so to speak. And some lessons about trying to pull them out, and some lessons about also, as you pull them out, for highlighting, not giving the perception this is still a project-based intervention. There are as many questions as answers, I think, on that, but I think it's a very important consideration. Governance and management. The MOH needs to be fully owning the intervention and leading it and managing it through its institutional structures, but it still needs to highlight it for additional attention. And there are ways, I think, that we tried to kind of pull this out when there was a technical work group that served as a resource team. We, as much as possible, wanted to put the resource team, so to speak, in, have it be developed and managed through that team, but it needed extra attention. So oftentimes that meant having a committee that was answering to overall resource team that was in charge of many different interventions. Costing, financing, and resource mobilization. We did costing exercises for all of these interventions. That data wasn't always used. It was in the Rwanda case and also in a less studied case that we did in Liberia as well. It was less so used in other places, mainly because there were much more pressing issues than the cost in some other places. Information and data use. Now, at a project level, we often have complex M&E systems. As we move to scale, that no longer is practical. And so we need to embed the information within the health information systems. In Rwanda, we had the most success. And interestingly, we were supporting 2 different interventions there. And there was more success in the postpartum family planning case than there was in the Helping Babies Breathe one. In the postpartum family planning, we negotiated with the ministry to put an additional column in the registry, and there was a lot of intervention to ensure data quality from the beginning. In the HBB case, we started out with very poor data quality, even though this was already integrated, and there we spend a lot of time in terms of trying to improve data quality. And then also learning versus what I call M&E. So you can use a randomized controlled trial, so to speak, or really rigorous M&E at an early stage, but it's neither practical nor appropriate as we go to expansion and scale up. And so going through rapid cycles of implementation and learning is really important, and mechanisms for having ways to have various districts sit down and discuss their information is important. There are often not mechanisms that ministries have for sharing among districts. They just kind of have a tree structure where they share up the chain, but not necessarily cross learning. And so this was something that was quite important for us to kind of negotiate as well. So there's a need in all of these cases for a couple of key things. One is the idea of accompaniment. So ideally, this is a demand-driven coaching kind of intervention that breaks out of normal project-based thinking. And there has to be some aspect of incentive structure that's aligned with best practices, like following. So we need to be able to show attributable results a lot of times. The incentive structure for us a lot of times is to be able to show fidelity to something, but that's already kind of pre-planned, but we need to think about how this will actually work in the real world. There also is a need for having, we thought, a scale coordinator, someone who's kind of the guru or the czar, so to speak, working across various systems. This was project-based in our case, but in most cases seconded to the ministry. We see no reason why this could not be in the future actually funded by a ministry themselves. Okay, so just a few conclusions about what worked well and what maybe didn't work quite as well. So it's very important to describe the intervention in a quite simple way in order to be able to have those kind of learning meetings and be able to know what's working well and what's not, to be able also to kind of be able to document what's being adapted and what's not as well. Also, the resource team, or the technical work group, it needs to have 1 foot in and 1 foot out of the MOH structure. It's not so much a discrete team as it is one that is kind of embedded within the overall structure of the ministry at the local, district, and national levels, but also with inputs from others, as Expanet has said many times. Having other donors and technical agencies as well. In a decentralized system like Nigeria's, this is very difficult to actually operationalize. Thinking about a scalable unit by which the MOH could actually manage the intervention. This is oftentimes the district. It shouldn't be just at a kind of local level because that doesn't bring in all the system elements. Using quantitative dashboards to be able to kind of look at what is actually happening on a downstream way and whether coverage is actually improving or not. Not just service availability, but actual coverage, using just a couple of key indicators and centering the learning discussion around that. So what were a couple of things that we could have done better? First, I'd say making sure the policy environment really is supportive before making a go decision, so to speak. I think in the Mozambique case with misoprostol, anybody who has worked on misoprostol in other places, or maybe even in Mozambique itself, knows that the supportive policy environment is not always as supportive as one might hope because of concerns about use of misoprostol, the safety of it, the use for other uses. And so even though there was actually a national policy and a national plan, there were those who were quite skeptical of it, and we had constant conversations about it that didn't allow the scale up to go forward quite as quickly as we would have hoped. And then also paying more attention to strengthening adaptive management and the incentives. I think this was something where it's not just kind of a capacity issue, but really looking at the incentives for actually using data and having the time to be able to do that. So among those who were at the ministry. So This is just some additional resources for those who are interested. Like I said, some of these things are in the peer-reviewed literature and some were self-published. And at the bottom are a guide and a basic toolkit that we used, that we developed as we went, so to speak, during our prospective cases. Thanks.
Well, thank you, Jim, really for sharing this rich experience of the Maternal and Child Survival Program and supporting, tracking these 4 countries and these 5 interventions over several years from a scale-up perspective. You helped us shine a light on the determinants and the impediments to scale-up success, some of them, in particular with regard to the resource team. And thank you for that. And the resources that you are sharing, we can make available after the session. It is time now to provide everybody time for questions. So I have a couple for the speakers, but I also want to enable you, since we're a smaller group, we could let you pose your questions yourselves, so you can turn your microphones on and your videos, as long as Janet enables that feature. And first, I will pose one that was received earlier from Rebecca Lundgren. Where did I put it? It's up a little in the chat. So here it is. Do you see any particular thoughts from your remarks about how to apply scale up across sectors? Are there any important differences that you would note? So the question is for Steve and Jim. And also, since the invitation is open, anyone else can weigh in on this question and comment and or pose another question. We have 10 minutes for this discussion, and then we'll switch into our group work. So Steve and Jim, would you answer that question first, please?
Okay. I mean, I think a number of the members of the community practice have been participating in kind of meetings of the wider multi-sectoral community of practice, and Larry Cooley, I think, has I think helpfully summarized this. Different sectors, because of the way they've been engaged with trying to move innovations forward, they have different things to share. Like a comment that he's made is that in the nutrition and food sector industry, and the private sector plays a hugely important role, and so there's maybe more to be learned from nutrition and food experiences with scale up than from many other sectors, but that can benefit us in health. There a lot of the interventions that we're working with involve use of commodities. I mean, Jim talked about chlorhexidine, misoprostol, and for some of these, like chlorhexidine was a new product, and so scale up country by country. One of the important pieces of that was to engage with producers. So this meant necessarily effectively engaging with private sector partners. So I think across the different sectors, like education, by contrast, it's very much a kind of a public sector focused activity, but like for the most part. And so the people working in scale up in education, I mean, they have things also to share with health from the way they've engaged with ministries at multiple levels, like at central level and then local, like with local school boards. So I think that the different sectors we're faced with somewhat different kind of system situations on the ground, and at the same time, a lot of what we learn is transferable across sectors. So for me, that's one of the reasons why this broader community practice that Johannes and Larry have drawn together, I think is so valuable, because I think we learn by analogy when we hear about how these challenges are being addressed in other sectors.
Great, Steve. That I definitely concur with everything you just said. Jim, would you like to also take a stab at that question about comparative learning across sectors?
Yeah, thanks so much for the question, Rebecca. It's a really good question that you posed in the chat. Just real quick, I agree with everything that Steve said. I would say this. This obviously was very public sector focused. And one thing I certainly learned already is not just to treat, as you already alluded to, Steve, a commodity as a black box. Procurement and supply chain was something I kind of just treated as, oh, it's out there, just to be kind of hoping that, things will work themselves out and we'll have enough of whatever. But I think taking, a page out of the private sector book, it's important to kind of think about market shaping, to think about, actually including the those who are involved with the commodity on the resource team, and think about it in a very explicit way and kind of pull them in to the kind of partnership in terms of making sure that scale up is happening well. That's certainly the case. I think one advantage that we have as well on our side in health is that we have some relatively good data for downstream sorts of information for outcomes. It's not easy to come by those outcomes, but we've had a long time and many years of thinking about what the outcomes are, how to measure them, in some cases, how to measure them relatively practically in a short term, kind of way so that adaptive management can happen. That's not as much the case in some other sectors like education, where maybe the one thing that there is kind of maybe pre-post test scores, but we're not really sure all the times how those actually correlate to real world outcomes or life chances or other things of that nature. I think hopefully maybe some of the thinking we've done in health can kind of help to translate into other places, and I think we certainly can learn from other sectors as well.
Yes, agreed. Jim, before I let you off the hook, you have a question about adaptive management and creating and the challenges inherent and creating incentives for the use of data. The question is, could you say more about what you meant and the strategies for incentivizing data use?
Yeah, thanks. I think we found a couple of really quick things that I can kind of say. This is a topic that could have lots and lots of discussion, but kind of a couple of quick things. One is that the idea of accountability is really important. And so if there is some sort of accountability built into a structure, and this takes different forms for different kinds of interventions or innovations. One that's been out there now for a number of years in a number of cases are community scorecards. It doesn't always have to be kind of completely quantitative data, but some kind of structured qualitative data as well. And having some accountability and having some built-in ways that people get together to discuss among various partners how they are doing and tracking on a community scorecard or on other kinds of scorecards that people use is important. On the other hand, accountability mechanisms sometimes can be a double-edged sword. People, in order to have an adaptive management stance, have to be open to bad news. And because not everything will work all the time. I definitely experienced this in some countries that there was such a incentive to show that one was doing a good job, that even if one was doing relatively a good job, if the glass was 80% full, one might say, the 20% empty was causing a huge amount of stress and anxiety among implementers. And that is not a situation that's conducive to good adaptive management and use of data, and not just kind of trying to show, kind of cherry pick your data. So that is definitely, an issue. I think anybody that's worked in certain parts of the health sector as well realizes that the most available data, like from health information systems, is often very messy and not of very high quality. And sometimes, unfortunately, even in the global space, we've incentivized less than ideal data, like ANC rates or immunization rates that are above 100%. And so kind of cleaning up that data and trying to, think about what it actually means, and trying to figure out what the true data is important as well. So this is something we could talk about a lot and kind of get into a little bit more, but just a couple of thoughts on that.
Good, and maybe we'll bring it into the next discussion because we're about to wrap up. I want to give Steve a last word, because there's a question from Anna about she appreciated hearing both of you use the term empty scale up. And I know this is a term that Steve coined several years ago. She's asking, what's the experience on unintended results that could potentially lead to scale up? Any practical examples of how that looks like in the interventions? So Steve, in about 1 or 2 minutes, maybe you could tackle that.
I'm not sure if I fully understand the question, but I'll take a crack at it. Part of this gets to points that Jim was making about the incentives, and we kind of need to have a kind of a permissive environment, like where the donor and the government that we're working with, and the other key actors, where we have permission to look objectively at how the program is actually performing. So there needs to be some seriousness among all the key players involved in a partnership on an effort like this. But if the incentives are not aligned to support that, we then have a stake in possibly in maintaining a fiction. So there's a narrative or a story about success that that people feel that they have to uphold, and that can make it very difficult to to recognize when a program isn't delivering. And there's a tendency that the bigger the effort, like the longer it's been going on, and the more that's been invested, the more difficult it is to acknowledge that performance, that it isn't doing as intended. So I mean, again, I think there are structural reasons. There's basic human psychology. Like, we have to really fight against this, and we need to find robust ways of getting objective eyes on a picture. So the idea of independent evaluation is good in principle, but I think we need to structure our efforts in a way where there really is opportunity to step back and do serious pause and reflection, so that there is the possibility of changing course. Like, if we can be learning, documenting, measuring, but if we're not prepared to take action that's kind of prompted by what we learned, then that learning and documentation hasn't helped very much. So I mean, it's a difficult nut to crack, and just the way our institutions work, and again the way human psychology works.
Good, great, thank you. And Dr. Hodgins has written a paper, I don't know if it's still a working paper, Steve, but on this idea of empty scale up, which is out in the public domain. So you can find that, Anna, and look into it a little bit more. So I hope that you enjoyed these 2 presentations. This is sort of exemplary of how the community of practice will convene in future meetings, and will bring together important voices in the field of scale up and try to share them and engage in dialogue. So now I want us to turn to our group work, which is First, I want to reiterate what our COP leader, Larry Cooley, indicated last Friday in the plenary of this annual meeting, which is equally true for this working group, which is that the proceedings are only as vibrant as you all make them. So as we shift into the groups, we hope you'll feel really comfortable sharing your input and help us to shape the future work of this health technical working group. If you, Janet, would put up the slide of the 2 questions that we're going to address in the group work, that would be great. We are going to be talking about 2 things. Sorry, is the slide there? Okay, she's getting it up there for us, but I'll also read it. The questions are, how can we best publicize and attract to the technical working group individuals with a strong interest in Scale Up from a wide range of health issues and topical expertise? And that's question 1. And question 2, what issues or topics related to Scale Up of different types of health interventions would you like to see the health working group focus on in future sessions? So Dr. Lundgren and I will split into groups with you, and I think you're going to be randomly assigned. And we will then come together and give a few highlights from the discussion topics that you are recommending we see raised in future meetings. So go ahead, events team, and if you would separate us into groups now, and then they'll give a warning and we'll automatically be brought back together at the end of the discussion. It may be abrupt warning, but you'll get a warning that time is running out. So
Hey,
Still muted. Yeah, it's just us because that attendee that didn't want to be in a breakout left. So
okay, and then Jenny Baker, is she?
she says, yeah, she says not joined, but I don't know why that is.
Jenny, can you hear us? I wonder if she says it's not. So you have her assigned to a room, but she's not there.
I think so. Let me double check.
It says not joined, and where her name is in the breakout.
Yeah, but her name's in breakout 1. Yeah, I had her assigned.
Yeah, she may be caught in. Sometimes it takes a while for somebody to. If she doesn't go there, hopefully she just leaves the meeting and rejoins. So we'll have to keep an eye out for her in the waiting room and let her back in, and then reassign. Re-put her back in there.
Okie doke.
I think it's probably on her end. Something is not connecting right or whatever. So, how long are they in breakouts?
Till 10:23. So.
Okay, so about, and that's when they're supposed to be back in here. Is it 10:23?
10:23 is when the breakout timer starts. So
Gotcha.
I'll end it at 10:23.
Gotcha.
It's 10 to 10:25 is their breakouts.
Gotcha. All right. Cool.
So I'll do the closing room because then it'll give that
Yep.
2-minute warning then.
Yeah, and then the cool thing about that is it just leaves the timer on everybody's screen the whole time while they're in there, so they know how much time there is.
And it's
Just
like
be
their
prepared
last call to
once-
wrap up. Yeah.
Yeah, once you hit it, people can leave on
They
their own
can
at that point.
choose to come straight back in here, so I'll have to slide up.
Yep.
I'm just leaving it up, honestly. I'll toggle to the next
Cool.
next one. Yeah. Awesome.
All right, cool.
And it looks like Jenny's gone now, so it looks like she just left the meeting altogether.
Okay, yeah, so let's keep an eye out, see if she rejoins.
I doubt it though. I would just peace out if I were her.
I just left the microphones enabled at this point because when they come back, they're kind of doing a group discussion, aren't they?
When they come back, it's just wrap up.
Oh, it's just wrap up. So then we should probably leave them muted then when they come back.
Yeah, that's fine.
All right, cool.
Great. Well, thank you and welcome back, everybody. I want to thank the groups, all of our members, for giving your thoughtful insights and input on how to shape both future membership in the COP